Good afternoon, everyone. Welcome to Stanford Cancer Institute's Breakthroughs in Cancer seminar series. This is our third installment. And our featured speaker today is Dr. Luis Diaz from Memorial Sloan Kettering Cancer Institute. First of all, on behalf of everyone in the SCI, I really want to thank all of you for coming, both those of you who are here in person and those on Zoom. Before getting started, I wanted to highlight the upcoming speakers in the series. So we have a slate of really exceptional speakers: Susan Domchek, David Hong, Jennifer Wargo, Charles Sawyers, and Ursula Matsulonis. So these speakers really are at the leading edge of cancer science in their respective fields, so I really encourage all of you to come to these seminars. A few procedure points. For those of you on Zoom, please add your questions to the Q&A box. And I also wanted to invite all of you to a reception that will follow immediately after this seminar with Dr. Diaz in B200, which is upstairs. So that'll have pizza and refreshments, so please join us. So now please join me in giving a warm welcome to Dr. Luis Diaz. I'm going to turn it over to Max Dean, who will introduce the speaker.
Great. Good afternoon, everybody. I first was asked to say that the format will be a 40 to 45-minute talk, then with 10 to 15 minutes of question and answer. And as Raj mentioned, this will include questions from Zoom if the Zoom audience has some. So now it's my great pleasure to introduce my good friend, Dr. Luis Diaz, as our speaker today. Luis did his MD at the University of Michigan and then went to Johns Hopkins for residency and medical oncology fellowship. And then he stayed on there as faculty, where he did some real groundbreaking work before moving to his current position at Memorial Sloan Kettering. He is a world-renowned GI medical oncologist as well as translational scientist, and he's currently the head of solid tumor oncology at Memorial Sloan Kettering. He has made influential contributions in a number of fields, including in immuno-oncology, where his work led to the approval of the use of checkpoint inhibitors in patients with mismatch repair deficient tumors, agnostic of tissue of origin. He's also a leader in the liquid biopsy field, which is how I got to know him, and really at the leading edge there also of developing and applying techniques for diagnosing and monitoring cancers. He has many, many accolades. I won't list them all because we'll be here all day. But currently he sits on President Biden's National Cancer Advisory Board. He's fellow of the AACR Academy and a recipient of the Giants of Cancer Care Award. So with that, it's my pleasure to introduce Luis.
Thank you, Max, and thank you for the invitation to come speak to you. I've done a number of talks over the past few months, and now that we're all coming out of COVID, it's really been great to meet with the fellows and graduate students, and I think that, to me, has been one of the more rewarding parts of these visits. Today I'm going to talk a bit about tumor intrinsic immunity and the features around it, and the underpinnings of this is really work that we've been doing. It's incredible to think about over a decade now, looking at molecular features of immunity and how best to use those for the management of patients. These are my disclosures, and most of these activities are related to entrepreneurship and working with companies both in the cell-free DNA space and on the immuno-oncology space and the oncology small molecule space. So I'm going to start very broadly and then get more specific. And we all know this paradigm of cancer evolution, evolving from a normal tissue to a premalignant tissue to one that's invasive to one that's finally metastatic. We know that if you look under the microscope histopathologically, there's characteristic changes that occur throughout each of these stages. And that if you look at the DNA, at least in this model of colon cancer, for example, you see accumulation of key mutations that either turn on or turn off genes in key locations that accumulate over this pathway of normal to premalignant to invasive. And one of the windows of opportunity that we've had is that this happens not overnight. This doesn't happen over weeks, but rather this happens over years and maybe even decades. And one of the advantages here, it gives you the window opportunity for potentially detecting these things very early. And we've pretty much defined these mutations that we measure in pre-cancer cells or cancer cells, but being absent from normal cells. And over the past 20 years now, I think that there's been a massive effort to characterize the genomes of adult tumors in males and females and pediatric tumors. And we have a general sense of the genomic landscape across all these different tumor types. So what do you do with all this information? Because last time I checked, I think there are over 3 million variants that are reproduced across a variety of different tumor types, and that comprises our somatic cancer genome data. And the real hope was that we could use these mutations and marry them to a therapeutic target, and the tumor would melt away. And that's happened, or there have been signals that that is possible with some therapeutics. And in some therapeutics, it works very well, and others not so well, but all dictated based on a genomic alteration and a drug that can specifically target that genomic alteration. But it hasn't been a tidal wave of therapeutics per se that have been highly effective. We've also used these markers as prognostic markers to tell us if a tumor is going to be more aggressive or less aggressive. BRAF in colon cancer is one such indicator. IDH in brain tumors is another indicator of aggressiveness or lack of aggressiveness of that tumor type. This is a world I know very well in liquid biopsies, and by here I'm defining mutations as a dynamic marker to look in bodily fluids for the presence or absence of cancer, for the growth of cancer, for looking for resistance mutations, or things like minimal residual disease. But I'm going to focus mostly on using these genomic alterations as immune antigens in a way to stimulate the immune system in a way that we can manage patients in a very positive way. And prior to these papers, most of my effort had been in genomically characterizing genomes or evolving liquid biopsies as a clinical application across a variety of different tumor types and indications. But these two papers were really monumental. But they were monumental, I think, primarily in one reason. They brought on the advent of checkpoint inhibition, which really has changed the way we treat many different tumor types. And it showed that these were effective in melanoma and kidney cancer, and that wasn't a stretch. We knew that these tumors were immunogenic. They oftentimes responded to cytokines like IL-2 or other cytokines like interferon alpha. We knew that you could get a cure rate even with those treatments. But what really set both of these apart is that they worked in lung cancer. And prior to that, immunotherapy had not worked in solid tumors, and lung cancer was a big surprise. And down the hall, we were working on characterizing genomes in tumors, and this was about 2005 to 2010, where this very simple observation had been made, which that liquid tumors and pediatric tumors had few mutations per genome. Sporadic adult tumors like pancreas cancer, breast cancer, gastric cancer had a relatively low number of mutations per coding exome, so about 75 to 100. But these mutagen-associated tumors, like melanoma and lung cancer, had many more mutations, about 150 to 300 mutations per coding exome. And these were the ones that were benefiting from immune checkpoint blockade, at least on the first pass of these therapies. And then down here, you have these tumors that are called mismatch pair deficient tumors. And I'll talk a little bit more about those. But those tumors tended to have thousands of alterations per coding exome. And probably the most common type of tumor, for sure the most common type of tumor with these alterations, were colon cancers. But 85% of the colon cancers were proficient with low number of mutations, and the deficient ones had many mutations. So a little bit about mismatch pair deficiency. It comes in two forms. There's a sporadic form and a hereditary form. The hereditary form is called Lynch syndrome, where you carry an inactivated allele of one of the mismatch repair proteins, and you get an acquired alteration during tumorigenesis that leads to mismatch pair deficiency. In the sporadic form, you have inactivation of both alleles of one protein in mismatch repair, and that leads to, well, and Lynch syndrome is a rarer one. It's about 15%, and the sporadic form is about 85%. So these are tumors with mismatch repair deficiency. If you have inactivation of mismatch repair, what happens is during DNA replication, you have the inability to recognize certain single base pair substitutions and short insertions and deletions. And that leads to the accumulation, as those cells divide, of mutations and what's called ultramolecular satellites, and we'll talk about that in a second. And that eventually leads what's called to microsatellite instability and an exceptionally high mutational burden enriched for insertions and deletions. And this understanding really began in the early 1990s. And this is work by Albert de la Chapelle and my mentor Bert Vogelstein and others that showed they were looking at the pathogenesis of familial colorectal cancer. And these were families where there was a lot of colorectal cancer. And what they were finding was that these patients, when they looked at their DNA, had alterations and repetitive sequences in their genomes. And when you looked across the proband and all the other patients affected in that family, they found that when you took each one of these, they found altered microsatellites, so repetitive elements across the genome, and they found alterations in those regions, and they call those microsatellites. And when they looked at these patients with replication error phenotype, they had them in a variety of different replication sites or microsatellites across the genome. And this happened not only in the Lynch syndrome, the spread or hereditary form, but a subset of the sporadic form. And one of the first papers to show that there was an underlying germline defect in mismatch repair was done by Nick Papadopoulos, and again with Bert Vogelstein, where they found a homolog to the bacterial mismatch repair protein and found it to be mutated in a subset of these families. Ramon Parsons with Paul Modell and Bert Vogelstein, again, early 1990s, showed that these mismatch repair deficient, or these RER, replication error defect patients, were hypermutable. They were looking at regions in the genome and just found multiple mutations across them compared to other tumor types. And then in 1994, at Hopkins, Stan Hamilton found something that pathologists had always known. These hereditary form of mismatch repair deficiency had a had an accumulation of infiltrative lymphocytes. And oftentimes pathologists said they knew it was a hereditary form of colorectal cancer because there was this massive lymphocytic infiltration. So fast forward to those papers where we saw the checkpoint inhibition. We had been doing all the sequencing of cancer genomes. We know these mismatch repair, these checkpoint inhibitors were having effects in things like lung cancer, melanoma with a higher mutational burden. So we proposed the following hypothesis, that what if these mismatch repair deficient tumors, because of their harbor thousands of mutations, and if expressed, they could potentially be recognized as foreign antigens. And since they're highly inflamed, could treatment with anti-PD-1 unlock a very potent anti-tumor response. So after a lot of back and forth and finding funding and actually finding the drug, we began to design this very simple study. And this was led by Young Lee while we were at Hopkins. And she took colorectal cancers, which are the most common tumor types with mismatch repair deficiency, and looked at those with deficiency in mismatch repair versus those that were proficient in mismatch repair, and finally had another cohort of mismatch repair deficient tumors of all tumor types. And we started this study about 2013, ended it in 2015, and we treated with a very high dose of anti-PD-1. It wasn't approved yet for any indication, so we had to struggle to get this. And we got funding from Swim Across America, 500 swimmers that jump in the Chesapeake Bay each year, and they funded the study. We couldn't get funding for this study. And all patients who we enrolled in the study had failed all lines of standard of care, and they had evidence of disease progression. So while we were conducting the study, I'd say 3 interesting papers came out. 2014, Tim Chan and Alex Slider showed an association in melanoma with CTLA-4 blockade, one of the immune checkpoint inhibitors, showing that more mutations was associated with more of a clinical benefit. And then in 2015, Nair Rizvi, Matt Hellman, and Tim Chan showed the same thing with another immune checkpoint inhibitor, anti-PD-1, that an association of clinical benefit in those patients at a higher mutational burden. Then Drew Pardall and Nicholas Losa at Johns Hopkins showed that mismatch repair deficient tumors had an elevation of all the checkpoints and an elevation of other markers of sensitivity to immune checkpoint blockade and metabolic checkpoints as well. So the stage was set. We had initiated the study in 2013, and we treated the first few patients, and what we found was the response was robust. And patients with proficient tumors, low mutational burden, normal DNA repair, their tumor marker, and in colon cancer, we're fortunate because we have a tumor marker called CEA, we can just draw it in the blood, we saw an immediate increase in the tumor marker there in red. But those patients with deficiency, you saw normalization in their CEA almost immediately after 1 to 2 doses. Now, we had some that didn't normalize, but the majority did have normalization quite rapidly. If we looked at the best radiographic response in the colon cancer cohort, those that were mismatch pair deficient all did very well, the majority responding, and those that were proficient tended to progress. In terms of progression-free survival, those that were proficient, low mutational burden, progressed typically within 2 to 3 months. Those that were deficient, the median progression-free survival was never reached and still has not been reached. And the same is true with overall survival, and median overall survival in the proficient group, low mutational burden, was quite short too, under 6 months. This is a prototypical patient treated with a periodic lesion, very nice response by 20 weeks, and a normalization of their tumor marker. So that was a colon cancer experience, and those were treatment-refractory patients, failed all lines of therapy. Now, what about other tumor types? Well, colon cancer in these studies was the most common, but we were able to find mismatch pair deficiency in virtually every tumor type that we looked for, albeit at a very low level. And this, as you can see here, is an incredibly long list. So if you look for it, you're going to find at least 1 or maybe less than 1% of cases that are mismatch pair deficient in other tumor types. And now these are metastatic cases. And so what we found here was a very similar response in that last cohort, the patients with mismatch pair deficiency from any tumor type, non-colorectal cancer. And one thing that was quite impressive is once you responded, the durability response was quite good. You were going to respond for a long time. And secondary or acquired resistance was unbelievably rare. And in terms of overall survival, not as good when looking at all the tumor types combined, because we did cross a median overall survival, but quite good compared to a variety of other therapeutics for these tumor types individually. But why did it cross a median here and not with colorectal cancer? So when we did an analysis of different tumor types, 2 tumor types stood out to us with not having benefit. These tumor types had mismatch pair deficiency, thousands of mutations, treated with the same anti-PD-1, and were treatment refractory, but it was brain cancer. None of them responded in our cohort. And pancreatic cancer, only 19% responded. And when we looked at the overall survival curves, pancreatic cancer and gliomas were the ones that crossed the median survival quite rapidly, and so did biliary cancer. Everything else, we did not have an overall survival, median overall survival reached. So something's different there. Something completely is different going on with those tumor types. I can kind of hand wave about what's going on with gliomas, and I can pretend I understand what's going on with pancreatic cancer, but it's very, very different clinical biology when treatment with checkpoint inhibition than all these other tumor types, despite having the same genotype as the other tumors. So just to summarize, in terms of approvals, because of that original work that was sponsored by a philanthropic group, Swim Across America, there was a breakthrough status for colorectal cancer in adults and children of any tumor type, the first tumor type agnostic approval by the FDA for a therapeutic with a biomarker. In 2018, nivolumab, another PD-1 block, was approved in colorectal cancer, again, all treatment refractory. And then in 2020, it was approved for this first-line therapy. So these are advanced cases. But let's pivot now to early-stage tumors. Remember, about 30 to 40% of patients are metastatic, but the rest of the tumors are early stage, and they're treated with surgery and postoperative or preoperative therapy. So let's start with early stage cancers. And there's a topic that's familiar to many people in the room, which is minimal residual disease. And this is something that is true in infectious diseases and hematologic malignancies, and we're now starting to think about it in solid tumors. And so remember when we talked about somatic genome data, liquid biopsy is one of the applications here. And liquid biopsies, as I suspect many of you are very familiar with, are fragments emitted of DNA or nucleic acids or proteins or even lipids from the tumor that can identify something or a mark in the tumor, either specifically or non-specifically. What I'm referring to are the alterations in the genome that are typically called mutations. And these small fragments of DNA from the genome are about 120 to 200 base pairs in length, sometimes shorter, sometimes longer. Very short half-life. They're typically undetectable after 10 hours. Their half-life's about 2 hours. and they allow for non-invasive real-time monitoring. Really, really hard to find. But the nice thing about mutations is that in most cases, if you find it in the blood, it's very specific to the tumor. And if you find more than one mutation in the blood, and that matches the tumor, that's going to give you an unbelievably high amount of specificity. And you can do a lot of different things with liquid biopsies. And a lot of these are very interesting, but the most promising is probably early detection, we think at this point. But I'm going to be talking about minimal residual disease. And so what is minimal residual disease? It's trying to do something that we've never been able to do in medicine in solid tumor oncology. Right now, a surgeon cuts the tumor out. They think they have it all, but they have no idea. The medical oncologist has no idea. No one has any idea. You won't know for 5 to 10 years if that patient's cured, if that patient had minimal residual disease after the surgery. And that surgery, that definitive therapy can be surgery, but it can be tailored with chemotherapy, radiation, or immunotherapy. And the hope is, can we use liquid biopsies to determine if there's any minimal residual disease early so you can determine who's cured and who's not cured? And I think one of the earliest examples of this in a solid tumor approach is a study we did with Carlo Rago a number of years ago, where we were looking at line 1 repeats. And we were looking at the line 1 repeats in tumors in mice and showed that we could measure in the cell-free DNA portion these line 1 repeats in a drop of blood, because there were so many copies per genome in this human cell. And we simply did this. We grew the tumor out, and then we cut it out, and we showed that the cell-free DNA could disappear. So, mouse study. Then, many of you probably have seen this before. In 2008, we did this with Frank Deal, and what we showed here using digital PCR is that before a surgery, day 0, 1 day after surgery, 42 days after surgery, and 244 days after surgery, for curative intent, a tumor, we could detect the mutations before resection, day after resection, day 42, day 244, CT scans negative at day 42, and CT scans finally positive day 244. The fragments went from 52,000 on day 0, but 1 day after surgery, there were some fragments left. Remember I told you the half-life? By 10 hours, it should all be gone. This is 24 hours later. There's still fragments there. Something's releasing fragments in the circulation. The patient had minimal residual disease. So we looked at a number of patients, and those with detectable ctDNA after a curative resection, and we measured it 6 to 8 weeks after surgery, recurred, and those with undetectable did not. So very preliminary study. There have been scores of studies now that have shown this using more sophisticated techniques. Max has been a pioneer in this, but you can name a variety of different tumor types and different scenarios in solid tumor oncology have done this. The problem is no one's shown any clinical benefit. Can you change the natural history of a patient who has minimal residual disease after you find it? Maybe you can give chemotherapy. It might work, but no one's proved it yet. We've looked at it retrospectively, and it might work. But those studies are ongoing. And this is an example of one of those studies. And this is led by Gillian Janjigian. And the reason I put it in this talk is because it's related to mismatch deficient cancers. And what she did was we looked at patients that went on R0 resection. That means the surgeon said he got it all. And we sequenced the tumor. If they were mismatch deficient, we let them get standard of care therapy. And then we measured circulating tumor DNA. And those that were positive either got pembrolizumab or placebo. Why pembrolizumab? Because we knew in the metastatic setting, mismatch deficiency tumors were highly sensitive to that therapy. If they were negative, we just observed them. And this was a ton of work because she had to screen all these patients right after surgery. She screened 174 mismatch deficient tumors, and we found 125 cases that were negative after standard of care therapy and 25 that were positive. This is all tumor types. This isn't just colon. This is colon, gastric, esophageal, prostate, pancreas, all tumor types. And so we enrolled them in the study. And so the patients that were negative, not surprisingly, did quite well. Recurrences were rare, and we had monitored them for a period of time, and we'll continue to monitor them. But this is consistent with what people are finding in the retrospective studies. One other caveat. We didn't care what assay we used to measure circulating tumor DNA, because if our requirement was that we had to find 2 or more mutations similar to the tumor, to the circulating tumor DNA, and we were looking for positives. Now, did we miss some negatives? Yeah, probably 1, 2, 3, 4, 5, 6, 7. So a better assay is going to detect about 7 more of those, which will be beneficial. But then we took another cohort and did not treat them. We treated them with placebo-like scenario, and those patients that were ctDNA positive and received a placebo recurred. There's 2 patients that we're continuing to follow, and we suspect they'll recur too. So what do you think happened when we treated with anti-PD-1? So when we treated with anti-PD-1, those that were positive mirrored those that were circulating tumor DNA negative. So we believe that we prospectively altered the natural history of these patients going forward, because at the time of looking for circulating tumor DNA, the time of looking for minimal residual disease, which matched the original tumor that was resected, we treated with anti-PD-1, and we were able to avert the conversion of a patient from circulating tumor DNA positive to tumor positive with this therapy. So moving even earlier in the therapeutic pathway, so metastatic disease, first-line disease, adjuvant disease. What about neoadjuvant disease before you do the surgery? And so rectal cancer is an excellent example of neoadjuvant therapy. Currently, it's treated with a combination of chemotherapy, radiation, and surgery. And cures frequently achieved. But as you can imagine, radiation to the pelvis and resection of the rectum have life-altering consequences. And a large percentage of these patients, about 30%, 40%, have ostomies for life. Following chemotherapy and radiation, a portion of these patients do have a complete response, and they're just monitored without surgical response, but they still receive chemotherapy and radiation. So when you looked at rectal cancer, about 5 to 10% of these cases are mismatch or deficient. Now, that number, as we test more and more, is probably getting lower and lower, but it's still significant. Currently, when we treat with chemotherapy, they don't respond. They're relatively resistant to chemotherapy. And we knew that checkpoint blockade was effective in the metastatic setting, but a complete response rate was only achieved in 10%. So we had this hypothesis. If we treated these patients before we treated them with chemotherapy or surgery or radiation, could we replace chemotherapy? Could we replace chemotherapy and radiation? Or could we replace chemotherapy, radiation, and surgery? And this is a study that was led by Andrea Sursek, and she did exactly that. We treated with an anti-PD-1 agent, dostarlimab, for 6 months. And then we followed these patients incredibly closely. Every 9 weeks, endoscopies, PET scans, and CT scans. If they had a complete clinical response, we just watched them, and we watched them very carefully. If they had any evidence of residual disease, we reflexed into the standard of care protocol. They got chemotherapy, radiation, and then eventually went to surgery if needed. And so this is the first patient, and this is the endoscopic view, the MRI, and the PET view at baseline. 6 weeks into therapy, we see a major response in the primary tumor endoscopically. And then over time, we saw a complete resolution of the tumor in this first patient. And we were pretty excited. This patient had very symptomatic disease, but with each visit, the patient, actually by the second time point at 2 months, the patient had no symptoms at all. So that was the first patient, very bulky tumor, nodes positive, had a complete clinical response. And we're out to almost 3 years now with this patient. So the following 14 patients all had the same complete clinical response. And none of them needed chemotherapy, none of them needed radiation, none of them needed surgery. And in those first 14 patients, the longest at that point had been 23, 24 months, but it was pretty incredible to us. And I think it's probably one of the first times this has happened in oncology where you fortunately treat patients and each patient has a complete response, and you can avoid the therapy that you naturally give or by standard of care, which is quite morbid. And since then, we've enrolled 55 patients. These are the 36 patients that I'm going to show you. But most of these patients in the beginning are approaching 3 years. And our definition, which is our secondary point of complete clinical response, which if you use that for standard care therapy with radiation and chemotherapy, is very, very highly predictive that you will not need surgery ever. So very promising data for us. When we looked histopathologically, most of the serial biopsies, and this is one of the advantages of the rectums with endoscopy, you could biopsy every time you went in. You cleared the tumor typically within 3 to 4 months. When we look at just standard histopathological markers of by immunohistochemistry of the immune response, what's interesting, and we've seen this in the metastatic setting too, you see an accumulation of biomarkers associated with an intense immune infiltrate, then a release, and then a steady state level down the road. The most remarkable one are B cells. And we see B cells actually at low levels in the beginning, but begin to establish themselves towards the end of therapy once the tumor is cleared, and you develop these tertiary lymphoid structures that are very rich in B cells, typically after you see a complete response. We don't know exactly why or what they're doing, or if the humoral immune response is important for maintenance or for the initial response. But this initial response of PD-L1 expression, typically on the stroma, then normalization, and then steady state level, again, with CD8 going up, and then normalization, and then a steady state level down the road is something that you see both in the local setting and in the metastatic setting. So initially, we saw 14 patients with a complete clinical response. We're up to 34 patients now with a complete clinical response, and 55 are being treated, and they're all doing well. We didn't see any severe adverse events. No patients required chemotherapy, radiation, or surgery, and currently no recurrences has been seen to date. So this rectal cancer data, I think, provides a framework for immunoablative therapies, highlights the impact of biomarker-driven therapy brought to earlier lines of therapy. The bulk of our work is being done with patients with metastatic disease. We need to start bringing our most promising agents and least toxic agents to the curative setting. I think this has the potential, much like the tumor-agnostic approval in the metastatic setting, to become a tumor-agnostic approval in the frontline setting or the early-stage disease setting. And it could eliminate the need for chemotherapy, radiation, surgery in about 3 to 4% of all tumor types, not just colorectal cancer or rectal cancer in this case. And we have these studies ongoing. We've treated prostate cancers, pancreas cancers, biliary cancers, a number of esophageal and gastric cancers, and we're seeing promising results there. But I think one of the ones that is often overlooked, but very important to us, and we're doing studies in Africa now to show this, is that this can be translated very rapidly into settings that don't have modern chemotherapy, radiation, or surgery. All you need is a diagnostic and now a sub-Q injection of anti-PD-1 for 6 months. So we're able to leapfrog the requirement of, let's say, an NCI-designated cancer center and just apply this at a distance using these therapies locally, and we're looking at this in Africa. What's interesting and what we found in Nigeria was that mismatch pair deficiency wasn't 5 to 10% in colorectal cancer, it was 25%. Now, we don't know why, but that's work done by Peter Kingham at Memorial Sloan Kettering, and that actually dovetails very nicely with the therapeutic work that we have here. So that's mismatch pair deficiency. But what about other hypermutant scenarios? There's another hypermutant scenario that's even rarer, probably less than 1% of all tumor types, and it's polymerase epsilon inactivation. And this can be hereditary and sporadic. There's another flavor of this, polymerase delta inactivation, and this leads to thousands of mutations in the coding exome. And these mutations in the coding exome tend to be primarily single base pair substitutions. And the inactivation doesn't occur in the polymerase domain, but rather occurs in the exonucleus domain. And this study was a fairly straightforward study done by Benoit Rousseau. And what was happening was we were getting patients that were being treated with mutations anywhere along the gene. And he simply showed that you had to have the alteration showing deficiency in the exonucleus domain, not anywhere else in the gene. And those that were deficient are the ones that benefited. Those were that proficient did not benefit so much. Fairly simple study, but to show you that other hypermutant scenarios are also benefiting from immune checkpoint blockade. So is immune checkpoint blockade everything? and is tumor mutational burden everything when it comes to the response there? And one thing I didn't tell you about is that in 2020, the FDA approved checkpoint blockade in a tumor-agnostic fashion for greater than 10 mutations per megabase. And this was done on one prospective study. There was no benefit shown and cure, so we were a little bit confused by that. And what was clear was that tumors with a low mutational burden, and here you have mutations per genome, and here you have objective response rate, those tumors with low mutational burden tended not to respond, whereas those with mismatch repair deficiency, polymerase epsilon or delta alterations, or what's called constitutional mismatch repair deficiency, they're born with both alleles gone at birth, and they have unbelievably high mutational burdens, responded very well. And these other tumor types were mixed responders. So Benoit and Mike Foote then looked at the following. Does tumor mutational burden alone really drive the response? And so looking at the Memorial Sloan Kettering cohort, we looked at patients that were greater than 10 mutations per megabase, so about 300 mutations per coding exome, or less than 10 mutations per megabase. And they did find a survival difference. But then they stripped out the mismatch repair deficient tumors and the polymerase defective tumors, deficient tumors. That includes polymerase epsilon and delta. And they found that the remaining tumors with more than 10 mutations per megabase really didn't benefit. They were no different than the low mutational burden tumors. And so they were able to segregate tumors into two groups. Those where TMB mattered, and those where TMB didn't matter. So TMB sensitive tumors and TMB insensitive tumors. And what was surprising about the TMB sensitive tumors is that they were all associated with an external mutagen. So non-small cell lung cancer, head and neck cancers, tobacco, and melanoma, UV light. And I want you to hold this thought for the end of the talk, but to us it suggested that if an external mutagen could be given to create a cancer, could you give an external mutagen to convert a tumor from TMB or insensitive to checkpoint blockade to sensitive? And so that was a thought that kind of emerged from this, but kind of just a general hypothesis that people talk about in the lab. What about mutational class? And this is a study that we did with Tim Chan, and I think it's remarkable for a couple of reasons. We knocked out MSH2, in these mouse cell lines, and the day after you knock out MSH2, they're mismatch repair deficient, but they're not immunogenic, and they don't have microsatellite instability. So what happens is that you have to passage these cell lines over time, and they have to undergo multiple passages, anywhere between 3 months and a year, and then they accumulate mutations, then they become microsatellite unstable, and then they become immunogenic. And what we saw was that over time, they would become more immunogenic depending on the number of passages they went through. And then when we looked at the human data, we also saw that the most immunogenic tumors were those that had the most mutations, and specifically the most insertion and deletions. And it set up the thinking of, well, insertion and deletions were present in this highly immunogenic tumor. And we know that we want tumors to be very antigenic or foreign appearing to the immune system. Maybe we can categorize mutations by foreignness, suggesting that tumors that were amplified or deleted or with point mutations probably were the least foreign looking if you think of the peptide that they eventually generate, whereas rearrangements, indels, and frameshift mutations would result in the most foreign-looking peptides if expressed. And remember, frameshift mutations are insertion and deletions, so short insertions of DNA bases or deletions in DNA bases that are not divisible by 3. So it will dramatically alter the open reading frame and the peptide that's eventually generated. Because it's not divisible by 3, it will be a completely new sequence. So what we did, and this is unpublished data, was we took an individual mutation and we did a reverse comparison to the self-peptidome using a BLAST algorithm. And then we took a collection of mutations that were given in a certain cell and did the same thing. And each of those had a score. And that score, if combined, would give you the number of alien peptides. So a single mutation can give you an alien peptide score, but a collection of mutations that were representative of a tumor in bulk would give you a tumor alien peptide score. And we were curious if that foreignness index would predict or tell us anything about the immunogenicity of that tumor. And so when we just basically did this on TCGA, not surprisingly, the most foreign-looking tumors were mismatch or deficient, followed those by POL-E deficiency, non-small cell lung cancer, and renal cancer, suggesting to us that the collection of mutations that these tumors had was highly foreign-looking. The mutations were resulting in peptides that, when you align them to the self-human peptidome, looked very foreign. And when we looked at mutation category, much like the list I presented, frame shift mutations followed by in-frame insertion deletions and missense deletions and splicing deletions were the most immunogenic, or the most foreign-looking. We're assuming that the most immunogenic. But back to that initial question about tumor or TMB-sensitive mutations. Could we then induce anti-tumor immunity with mutagenic agents by tailoring chemical mutagenesis to give us a genotype that we wanted that would potentially be immunogenic? So could we do pharmacologically recapitulate mismatch deficiency in a mismatch proficient background? And one of the things that we knew at this point were that the response checkpoint blockade are associated with high TMB that was highly enriched for frame shift mutations. That was what we knew in mismatch deficient tumors. And so that was one truth that we thought was true. But there are many barriers to this approach. One was there's an overriding opinion that random mutagenesis will lead to random neoantigens and that you need a clonal neoantigen for a potent immune response. So if we chemically mutagenize a tumor, you're going to get all these random mutations, so you won't have a clonal neoantigen for the immune system to respond to, and it won't work. The second is, if you give a mutagen, what about all the normal tissue? Are you getting mutagenized normal tissue? Could you induce cancer in the normal tissue? And obviously, cytotoxicity will just be killing off cells rather than inducing immunogenic tumors. So Benoit took on the challenge. Benoit Rousseau in the lab, and through a variety of methodologies, selected a group of drugs that were mutagenic, typically drugs that humans want to avoid, and we exposed them to 8 weeks to mouse cell lines, and washed them out, and then did a number of different things here. We did a high-throughput screen with the syngeneic immune cells. We looked at the genetic landscape, and then we looked at preclinically at confirmation. And I'll show you a combination here that's semi-public, but there are a number of drugs that have very interesting mutagenic features that result in immunogenic tumors. But the reason we chose these two, this combination, is we knew temozolomide induced a large number of mutations, and cisplatin induced a large percentage of insertion deletions. And so using this model, we did the following. We treated with 8 weeks of the combination, and we did the combination cisplatin alone, temozolomide alone, and no drug alone. And what we found was when we did no drug and looked at the genome, these are histograms of exome sequencing in bulk, the tumor mutational burden went down a little bit, but it's pretty much stable. The MSI score, which is a genome-wide measurement of all the microsatellite alterations in the genome, stayed pretty much the same. Missense mutations went up a little bit, and frame shift mutations went up a little bit. We looked at cisplatin. Again, a slight increase in TMB. The MSI score went up a little bit. Missense mutations went up about 600, and frame shift mutations went about 16. Interestingly, here, these tumor mutations remained highly subclonal, you do get a clonal peak here. And we think cisplatin is actually selecting a bit for a subset of tumors, and that's why you get a clonal shift. What about temozolomide alone? We know this induces a lot of mutations. Here, the tumor mutational burden went up by 11 mutations per megabase. The MSI score stayed the same. Missense mutations went up by about 500, and frame shifts went up by about 15, and you still see that subclonal pattern. But when you combine them, you see a huge increase in tumor mutational burden by over 100 mutations per megabase. The MSI score then becomes in the mismatch pair deficiency range. The missense mutations go up by 12,000, and the frame shift mutations go up by about 1,600. So big difference. When we look at the mutational signatures of the gains, you see, and we look specifically for the signature for mismatch pair deficiency, this signature is very pronounced in the combination, absent from the vehicle, slightly present in the temozolomide and cisplatin. When we inject these into mice and compare vehicle to the combination, and you look at CD8, you look at a monocytic marker, and you look at PD-L1, you see PD-L1 goes up significantly compared to vehicle. The monocytic infiltrate is quite dramatic, and you do see an increase in CD8 cells. And then when you inject them into mice to look for two things, is there a delay or a rejection in growth? And if there's any growth, treating with anti-PD-1 make the tumor go away. So parental, treated with vehicle, you really don't see any difference with anti-PD-1 or the IgG control. Cisplatin alone, you really see very little difference. Temozolomide alone, in purple, you see a little bit of a benefit with anti-PD-1, but not that dramatic. As a control, a mismatch pair deficiency positive cell line that had been cultured for probably 2 years. Not much delay in growth, but when you add the anti-PD-1, you see some delay in growth. But when you treat with temozolomide and cisplatin, you do see a delay in growth, even with IgG1 control present. And when you add the anti-PD-1, that growth completely is eliminated. So there were another number of studies that we did after this where we prospectively treated mice with tumors that were mismatch pair proficient, and we were able to see conversion to a mismatch pair deficient genotype and efficacy with anti-PD-1. And because these drugs had all been given to humans, and as oncologists we know how to give them, Neil Siegel in our group proposed, let's go ahead and try this in patients. And we did a very simple temozolomide plus cisplatin plus nivolumab, an anti-PD-1 agent. And what was interesting is that in 3 patients, we were able to see a dramatic increase in TMB. In 80% of patients, we saw an increase of microsatellite signature. And this is an early signature, but those patients with the highest TMB signature had disease stabilization or benefit. And more data is cooking here, still very early in these studies. So to conclude, we think that these are examples of cancer genomics to the management of colorectal cancer and to some tumor agnostic indications. We think that tumor intrinsic genotypes like mismatch pair deficiency, POLE, and TMB are highly associated with preclinical and predictive exquisite sensitivity checkpoint blockade. And we think that recapitulation of the MMRD signature induces immunogenicity in preclinical models and will allow us to translate this into human models, both in the localized setting and in the metastatic setting. And finally, neoadjuvant therapy may pave the way for immunoablative therapy, which is already present in tumor types where surgery isn't involved, but moving it to solid tumors, I think, will be impactful. So I always like to thank the giants whose shoulders we stand on. Henry Lynch, who passed away recently, and Albert Del Chapelle, who were really fundamental and instrumental in shaping the early development of this therapy. And it was nice that both of them got to see the inception of the work and where it eventually got to that allowed us to treat patients. Obviously, the patients and the family and the sponsors, the laboratory at Johns Hopkins, the group at Memorial Sloan Kettering and Yale, Stand Up to Cancer and the teams involved in that, and the lab at Memorial Sloan Kettering. I'll stop there and thank you for your attention.
Luis, great talk as always. Question for you. The temozolomide cisplatin data, I'm just wondering if you have any comparable data with radiation. For some solid tumors, we're thinking more about radiation in the neoadjuvant setting and whether that should be used, not necessarily as a curative intent, but as sort of priming for immunotherapy.
Yeah, thanks, Allison. And good to see you. If you look at radiation, and then you look at after, if you give radiation, look after, you don't accumulate that many mutations. So that's one thought. The second thought is could you induce a danger signal locally, and that would prime the immune system in such a way that coming in with immune checkpoint inhibition, or maybe naturally you'd get an immune response. And there have been studies that have shown that if you give either stereotactic radiation locally, you will get priming to the tumor that you've irradiated, and you will get response checkpoint inhibition at tumors distant from the radiation. However, I don't know if it's that response to the checkpoint inhibitor alone, because I haven't seen randomized control studies of that. They've typically been single-arm studies. So the response rates are kind of within the range of maybe PD-1 alone, but not completely explainable by the addition of radiation. Either way, most of those responses are short-lived. We don't see a permanence of that response. So my concern is that you'll see a transient response, but it'll be probably it'll be short-lived.
Luis, in hematologic cancers, particularly a few lymphoma types like Hodgkin's disease, mediastinal lymphomas, and gray zone lymphomas, have exquisite sensitivity, even if it's short-lived, to checkpoint blockade despite very low mutation burdens. Would you care to speculate as to what might be driving those responses if the antigen burden is so low?
Yeah, what's interesting is that, and I don't know if are those virally related or not.
Even in the non-virally related ones,
Yeah.
We get pretty dramatic responses.
What's interesting in anal cancer and head and neck cancer, which are HPV driven, the response to checkpoint blockades is what I'd say lukewarm. It's not fantastic, and I've been actually surprised at the response that we see in these low mutational burden tumors like the ones that you're talking about, and we've put all our eggs into the DNA basket, but I suspect that there are alterations either in the non-coding region of the genome potentially, or alterations in the RNA that still haven't been identified that lead to potentially misfolding or protein misfolding that could activate some other immune system. But I don't have any direct evidence of that.
In your paper, you allude to the microbiome potentially influencing the response. I was wondering if you could elaborate.
Yeah, and we're actually putting that paper together. So it appears that tumors that are PD-L1 high create immune privileged site. And in luminal tumors that have access to bacteria, they have a higher mutational burden. Microbial burden. And whereas if you have a parenchymal tissue, let's say in the pancreas or in the liver, and even if it has a high PD-L1 expression, it has a low microbial burden. The hypothesis is that when you have a luminal tumor, like a rectal cancer, that has high PD-L1 because it's mismatch deficient, the bacteria hide there as well. You treat with anti-PD-1, and not only do you have a very potent anti-tumor response against the tumor neoantigens, you have a very potent, probably innate response against the bacterial antigens as well. That paper is being crafted right now, but I think because it's in a dirty environment like the GI tract, it's tough for us to make that into a definitive argument, but that's what we're leaning towards at this point.
Sure.
Hey, it was interesting that you had renal cancer in there as a high immunogenic tumor, along with, skin with melanoma and lung and mismatch repair. What you think the mutagen is there if it's not exogenous with renal cells? Like,
So renal cell was in the non-exogenous one.
okay, I thought-
Yeah. So it was in the bottom.
Yeah,
So that just may be garden variety bad luck.
yeah.
Yeah.
So I really like that last trial with the temozolomide cisplatin mutation induction. I would imagine that will be different number of mutations per cell, obviously, it's going to be a heterogeneous process. So have you on the trial seen patients that look like they had responses but then progressed again? And if they do, that those tumors that grow out are ones that didn't get so hyper.
So I'm showing you early data, obviously, but what we're seeing, we have 3 patients that had a doubling of their TMB. Those patients have stabilized; they have not progressed to date, and they're doing well. But I suspect exactly what you're talking about is that if they grow out, they just weren't hit by the mutagen. My hope is that there'll be a bystander effect, and that's always the hope, of that a non-targeted therapy or an immunotherapy in this case will eliminate the rest of the tumor.
Stephen? The MRD adjuvant trial data looked really promising. Just curious, did any of those patients also receive adjuvant chemotherapy, and could some of the benefit of the immune checkpoint blockade be overcoming any deleterious effects of chemotherapy in that population?
Yeah, so all of them received a standard of care, and because it was a mixture of tumor types from really all parts of the body, it was very heterogeneous. So it's hard to make that conclusion, but potentially. Yeah.
Thanks for the amazing talk. I have 2 questions about the temozolomide cisplatin combination treatment that you give now to patients, which is amazing. First one is, did you also treat like normal cell lines or, for example, normal organoids with this combination? Do you see a similar effect on the mutational burden? And the second question is, you started the trial combining these 3 agents, right? Like temozolomide, cisplatin, and immunotherapy. Should you not wait?
Yeah, the IRB wouldn't let us, which makes sense. But to your first question, we did treat human cell lines, and some tumor cell lines are very sensitive, and other tumor cell lines are not so sensitive. And we think it may be methylation status, but we're not sure. But that's also being recapitulated in the human data, that a subset of patients didn't have a higher mutational burden after a few treatments, whereas the majority did not. So there is heterogeneity there. Mouse cells are much more susceptible to mutagenesis with these agents than human cells. So there may be a more expansive mechanism of DNA repair that are redundant in the human cells.
Just want to remind you about our next seminar, which is on April 11th. That's Susan Domchek from Penn, and her topic was Genomic Medicine Means Cancer Interception. So we hope to see you there. All right, thank you again, and please thank me.